Greetings and welcome to another academic half-day for critical care fellows. Today I'm going to talk about a topic that encompasses three different disorders and lump it together into the broad category of ischemic enteritis. This is an important topic because the overall incidence of the disease is relatively low, but the consequences of these conditions are very high. Now, within the category of ischemic enteritis, we're going to cover the acute mesenteric ischemia, mesenteric vein thrombosis, and then finally ischemic colitis. For each one of these, we'll go over the individual risk factors, the pathophysiology, the clinical factors, how you make the diagnosis, and an approach to the treatment of them. So to start, let's begin with the acute mesenteric ischemia. Now, for the purpose of this half day, I'm going to assume you have at least a working knowledge of the general anatomy of the mesenteric arteries and veins. But suffice it to say that most of our focus will be on the superior mesenteric artery and the inferior mesenteric artery, as well as the superior mesenteric vein. These flow off of the aorta and supply both the large and small intestines, and for the inferior mesenteric artery, mostly just the colon. So now, acute mesenteric ischemia is generally a disease of the superior mesenteric artery, and there's really two mechanisms by which this can occur. One is through an emboli from somewhere more proximal, or through gradual thrombus development and then eventually complete occlusion. Now, arterial emboli primarily come from sites more proximal to the superior mesenteric artery, generally from the left atrium, the cardiac valves, and then the proximal aorta. More uncommonly, you can get a paradoxical emboli across a patent foramen ovale, but that gets to be a little less likely as in terms of overall etiologies. The superior mesenteric vein is particularly prone to receiving emboli because of its positioning. It has a very large diameter relative to other vessels, and it also has a narrow takeoff relative to the aorta, which makes it much more susceptible to receive emboli. And because the superior mesenteric artery also takes a fairly large amount of the total blood supply from the cardiac output, there's a higher probability that things get into that artery. The inferior mesenteric artery is much less likely to be involved in an embolic event because it has a much smaller caliber overall. Now, when a clot gets into the superior mesenteric artery, it in general will go about 3 to 10 centimeters distal to the origin of the SMA, because there's a section there that's tapered near the takeoff of the middle colic artery. And so about 85% of all emboli will get that far south, whereas about 15% will get plugged at the origin of the SMA. Therefore, the middle segment of the jejunum, which is also a little bit more distal from collateral circulation of the celiac and inferior mesenteric arteries, is usually one of the first sections to be involved in any ischemic process, and the proximal jejunum is usually spared in all of this. Now, in contrast to emboli, thrombus is a different beast. Thrombus is usually the result of progressive narrowing due to atherosclerosis. The acute thrombus will occur mostly as a superimposed phenomenon in patients who have some form of chronic mesenteric ischemia or intestinal angina, which is often usually referred to as acute on chronic ischemia, period. This thrombus will develop in the SMA, usually at the origin, or even a little bit further up in the celiac axis. And in order for somebody to have symptomatic disease, you usually have to have at least two of the major arteries involved before symptoms will develop. This is in part because of the progressive nature of the disease allows for the collateral vessels to form in order to try to bypass and accommodate for the stenosis. Now, while thrombus is usually associated with the presence of ongoing and a history of atherosclerosis, peripheral vascular disease, you can occasionally see mesenteric thrombosis occurring in the setting of trauma, where there's a vascular injury, when there's been an infection, such as a mycotic aneurysm that has, or an emboli from an endocarditis which has formed a mycotic aneurysm, can then serve as a source for progressive thrombus formation. You can also get thrombus formation over time if there's been a dissection, or especially when patients have had an acute on chronic condition. And part of the treatment regime has included progressive angioplasties or stents. The site of the stent can serve as an ongoing source of thrombosis. So now there are a number of risk factors associated with the development of acute mesenteric ischemia, and these include those that are risks for embolic disease and those that are at risk for developing thrombosis. Embolism obviously is more likely to occur in patients who have an underlying arrhythmia like atrial fibrillation. Similarly, anybody who has valvular disease who is at risk of developing microemboli that can then fly off, or even conditions like endocarditis, are also at particular risk for developing mesenteric ischemia. Myocardial infarctions also present as a potential risk, primarily from the development of thrombus within apical regions if they're akinetic, and as well anybody who has any form of ventricular or aortic aneurysm is also at high risk for developing clots and then embolizing those clots distally into the superior mesenteric artery. Obviously, people who are at particular risk for developing thrombuses are individuals who are already predisposed to developing them in other areas of their body, and especially if they have a peripheral vascular disease. And usually these patients have a known history of peripheral vascular disease before they go on to develop mesenteric ischemia. But there are also a number of other conditions that can predispose patients to developing thrombosis, and that includes an underlying history of vasculitis, and particularly the small medium diameter arteries are particularly predisposed to developing thrombuses and occlusions or even spasm. And so the paradigm disease in this circumstance would be a polyarteritis nodosum, particularly with these people at risk. Histologically, these people will develop fibrous intimal thickening, which decreases flow through the artery. And then finally, any individual who's had a previous trauma, abdominal is also at risk for having either dissection or of developing a direct thrombus from injury to the mesenteric artery itself. And so a recent history of trauma needs to be kept in mind as a risk factor for ischemia. One of the greatest challenges in this particular condition is the fact that many of the clinical features are relatively nonspecific, and it is only when somebody develops infarction or obstruction or perforation does it become obvious what the source of the problems are. So early on symptoms and clinical signs, including even the lab studies and plain films, are usually unhelpful. But The condition needs to be kept in mind, particularly within the classic presentation of a patient who has abdominal pain, and complaining of it is quite acute, but when you examine them, they actually have minimal findings on examination. And then in that context, also having a metabolic acidosis that is otherwise unexplained should raise the suspicion that the person is developing mesenteric ischemia. Now, an abdominal flat plate or CT scan can help with making the diagnosis, but they don't necessarily exclude ischemia. But at the same time, they can also help make the diagnosis by demonstrating the complications of the ischemia, such as necrosis and perforation, and also help you exclude other causes like obstructions and volvulus. So the classic triad is the elderly patient who has a history of atrial fibrillation, who presents with abdominal pain out of proportion to their clinical exam. Now, this happens only to have occurred about a third of the time, but when you see it, it's important that you at least you recognize it and act accordingly. One thing to note is that blood in the stool is much less common to see compared to other conditions related to mesenteric ischemia, and it can be present only once the ischemia becomes much more advanced. Oftentimes, the development of mesenteric ischemia is the first clue to the development or to the presence of a bacterial endocarditis. But in the cases where patients are known to have endocarditis, the risk of emboli occurs within the first 4 weeks of initiation of therapy. And it also patients who have larger vegetations, staph infections particularly, are at higher risk for developing emboli and ischemia. And then also, obviously, when the vegetation is growing despite a therapy, these are all things that present as significant risk factors and should clue you into the possibility that this patient with endocarditis who's presenting with abdominal pain probably has mesenteric ischemia. In the case where there's a known history, or when there's thrombosis is the cause of the mesenteric ischemia, usually there's a known history of peripheral vascular disease that precedes it, and when you explore with the patient their past history, you usually find that they have a history of chronic ischemia or intestinal angina. Now, intestinal angina typically presents as a picture of an individual who's losing weight for over 6 months and has developed a progressive food aversion because they develop abdominal pain after about an hour after they've consumed any sort of food. Sometimes people will deny any food aversions, but unconsciously have been slowly decreasing total fat intake in their diet as they've learned unconsciously that this is associated with abdominal pain subsequent to eating a meal. Now, even though many of the other clinical features are relatively nonspecific, indications are usually not as particularly helpful early on, a CT angiogram is usually the investigation of choice that will actually make the diagnosis for you. So if you have a suspicion when you send somebody down for a CT scan, consider whether or not you want CTA as well. Now, once you make the diagnosis of mesenteric ischemia, or at least at a point where you have a reasonable suspicion, there are a number of general management strategies you can start in order to try to reduce the risk of progression and clinical deterioration. First and foremost, obviously, is you should make sure the patient's NPO, and if they don't have a tube in, nasogastric tube in, you should probably have one inserted so that you can keep the stomach nice and empty and don't get anything, don't move anything into the duodenum. Obviously, you should keep the intravascular space well hydrated with intravenous fluids, and if at all possible, try to avoid starting vasopressors, and certainly when an individual develops intestinal ischemia, certainly the initiation of vasopressors will make the ischemia worse, but also you should consider that if you need to start vasopressors, they're deteriorating to the point where you should probably think about more aggressive, more aggressive steps. If the patient is appropriate for it, you should also seriously consider starting empiric heparin in order to reduce their risk of further emboli. And then also there's evidence for the use of empiric antibiotics as the bowel becomes leaky in the presence of its injury, and the risk of bacterial translocation is real. Obviously, as well, you should also consider starting a proton pump inhibitor to reduce acid production and load on the duodenum, and again, following the usual principles of ABC, and capture the airway if they've developed obvious signs of shock. These people should have an early referral to a surgeon for consideration of surgical management. And if the patient is deemed not a suitable or a very poor surgical risk because of other comorbid conditions, can continue to be managed conservatively, but if they develop a transmural infarction, then they are unfortunately probably best just palliated. As a rule of thumb, and this should go almost without saying, anybody who develops signs of obvious peritonitis, including free air on CT scan or flat plate, pneumotosis, and those types of complications should be taken to the operating room sooner rather than later. Because once in the operating room, the plan is to do essentially an open embolectomy followed by resection if there's obvious areas of that have infarcted, or areas particularly that are at risk. Now, if the ischemia is actually due to thrombosis, then in that case, the option is not necessarily embolectomy, or even endarterectomy, but usually some form of bypass. And because of the nonspecific presentation of most of these patients, and the fact that they usually present in extremis before they go to the operating room, they're often the operation is not the intention of resecting and then reanastomosing, but more of a damage control operation, unless of course a peak and shriek is the findings, and the patient is instead brought back for palliation. Now, in circumstances, a patient may present with obvious ischemia present on CTA with an emboli or thrombus responsible, and but they are actually relatively stable. And in centers that are with this, they could be instead referred for some form of endovascular procedure in order to try to clear the clot or relieve the obstruction. Now, these patients have to have absolutely no signs of advanced ischemia, and this should be a decision that's made in concert with both interventional radiology and general surgery, because an interventional or endovascular procedure will not allow for direct visualization of the bowel, so the decision about resection and identification of areas of infarction is notably absent. The endovascular procedure should be performed within 8 hours of symptom onset for best results, and also to reduce the risk of missed bowel infarction, ultimately requiring surgery. The endovascular approach with an emboli includes any form of intra-arterial TPA, similar to what is done with ischemic strokes. Or alternatively, they can use direct clot extraction if the clot is amenable to that. In the case of thrombosis, then a more traditional angioplasty and stenting procedure is usually the endovascular treatment of choice. Once the patient has recovered from their initial procedures, whether that's surgery or endovascular, the long-term treatment is for anticoagulation, usually with heparin. As is currently, there's no obvious evidence or role for the use of direct thrombin or direct 10A inhibitors at this point in time. Now, the next area of ischemic enteritis that I'd like to cover is the mesenteric vein thrombosis. This is a condition that is rarely seen, but is probably a bit more common than usually identified. In this particular talk, I'm not going to cover more proximal clots like the portal vein thrombosis, nor at the same time am I going to cover the chronic mesenteric vein thromboses, which are a bit of a different beast, and instead focus on the acute presentation of the patient with mesenteric vein thrombosis. Now, the conditions that cause mesenteric vein thrombosis are the same as the factors that cause venous thrombosis in other parts of the body. Particularly, Virchow's triad applies. As you will recall, this triad is the combination of stagnation of blood flow, vascular injury, and hypercoagulability that all contributes to cause blood clots in the venous system. In the case of mesenteric vein thrombosis, local factors such as recent splenectomy or pancreatitis tends to create the conditions for thrombosis in the large veins, whereas the hypercoagulable states such as genetic predisposition and systemic malignancies tends to cause thrombosis in the smaller intramural venules and venous arcades. Interestingly, the inferior mesenteric vein is infrequently associated with clotting, and the vast majority of these cases always involve the superior mesenteric vein, which leads to clots involving the distal small intestine, such as the ileum and the jejunum, while still sparing the colon period. The sequence of events that leads to injury from venous thrombus in the mesenteric veins starts with the development of an acute occlusion in one or more of the mesenteric veins that then extends more proximally. First, there is a reduction in the perfusion pressure because of the increased resistance in the mesenteric venous bed. This is followed by bowel wall edema that leads to submucal hemorrhage. And then as the venous arcades and vasorecta are involved, then the bowel wall can become completely infarcted. Interestingly, the incidence of intestinal infarction is not 100% in the case of mesenteric vein thrombosis, and a chronic condition can develop instead. Now, no single condition in and of itself can lead to mesenteric vein thrombosis, as Virchow's triad points out. There are a variety of risk factors for the development of venous clotting that include both inherited and acquired conditions. More local intra-abdominal inflammatory processes like you would see with inflammatory bowel diseases or pancreatitis, tend to cause clotting in the larger veins, whereas the inherited conditions and thrombophilias tend to cause clotting in the smaller vessels. Conditions that lead to mesenteric vein thrombosis include abdominal masses by their effects both on the vascular wall through injury, but also through direct effects from compression, abdominal inflammatory processes like pancreatitis, diverticulitis, and inflammatory bowel diseases, as I just mentioned. And then more systemic conditions such as myelodysplastic syndrome, which tends to create a hypercoagulable state. The presence of increased portal pressure and portal hypertension also causes stagnation in the venous system and can lead to clotting. The presence of previous history of venous thrombosis or a family history of venous thrombosis should raise your suspicion for a mesenteric vein clot, as well as anybody who has a acquired thrombophilia that can be generated from malignancies or medications such as contraceptive pills. Other inherited conditions that lead to thrombosis include the usual class of bad actors, including factor V, Leiden mutation, prothrombin G202, 10A, protein CNS deficiencies, antithrombin 3 deficiency, activated protein C resistance, and the family of antiphospholipid antibody syndromes. Finally, any recent sclerotherapy that was done for esophageal varices places a person at increased risk of developing mesenteric vein thrombosis, in addition to the fact that they already have portal hypertension. The clinical presentation for mesenteric vein thrombosis in many respects is similar to the symptoms that patients will present with when they have an arterial occlusion. The pain is usually described as colicky and mostly located to the periumbilical area, with a several-hour duration of onset before seeking medical attention, and then on physical examination, the degree of pain is usually out of keeping with the physical exam. The pain is a little bit duller than that which you would expect with a arterial occlusion, and in many circumstances will even be present for several days before somebody presents to hospital for evaluation. Different from arterial occlusions, the finding of occult blood is much more common, and there will also be some generalized abdominal distension. However, you will not likely find a lot of signs of peritonitis until the bowel becomes completely ischemic. As well, the peritonitis will usually be accompanied by a loss of bowel sounds. Once the bowel wall itself becomes ischemic, then the presentation in many respects mimics that of arterial occlusions, with the development of pneumatosis and peritoneal findings. As you can expect with people who have nonspecific findings, making the diagnosis of this is also difficult and requires a high index of suspicion. A flat plate of the abdomen will usually only show distended loops of bowel, and you will sometimes see some thickened bowel wall associated with the diffuse edema from the impaired venous drainage. And then as the necrosis advances, you may start to then see signs of pneumatosis, but this is a late finding. Interestingly, the MRI is the most sensitive method for diagnosing mesenteric vein thrombosis. However, it's obviously inconvenient, and a CT scan is usually the test of first choice. CT scan will typically demonstrate venous filling defects or an absence of flow. And in addition to other findings such as a reflux of contrast into the aorta, an enhancement of the bowel wall with delay of clearance of the contrast through the venous system. As the edema advances and the bowel wall becomes ischemic, you will then start to also see other findings such as mesenteric stranding that then eventually progress onwards to changes associated with bowel obstruction. The bowel wall becomes increasingly thickened, and once it's over 3 millimeters, there's a much higher risk of infarction developing. Occasionally, if you catch this condition late, the presence of pneumatosis and portal vein gas will be fairly obvious. Occasionally, especially in conditions of acute on chronic thrombosis, you'll see evidence of portal hypertension or ascites that indicates that this may be a bit more of a long-standing problem with the acute component to it. There are not a lot of blood tests that can be done that will help identify this problem and help distinguish it for conditions, but doing blood workup for hypercoagulable states is an important part of the investigations for venous thrombosis, and including all of the other conditions that I've listed earlier with factor V, C and S deficiencies, antithrombin 3 levels, prothrombin mutations, activated protein C resistance, and the lupus anticoagulants and their family. The difference between mesenteric vein thrombosis and arterial occlusion in the management is the difference between conservative and operative management. Whereas in an arterial occlusion, the focus of therapy is on open embolectomy and resection. With mesenteric vein thrombosis, the goal is to pursue a more conservative course and hopefully have this settle without requiring surgery. Obviously, systemic anticoagulation should be started, again, heparin being the gold standard, and there's very little role, especially at this point, for any of the other anti-10A and antithrombin inhibitors. Repeated clinical examinations is important, and repeated imaging may be necessary in order to identify complications from the thrombus and to identify patients who require surgery. Now, surgery will be required in up to a third of the patients who present with this, and again, the individuals who should be referred for surgery include those who have obvious signs of infarction, peritonitis, obstruction, or have demonstrated an unresponsiveness to conservative management, anticoagulation. As well, we should always continuously monitor the bladder pressures to look for signs of intra-abdominal hypertension, which could force the hand of surgery, even in the case where there's no obvious bowel obstruction or infarction. If it becomes obvious that surgery will be necessary, then surgery should proceed without any delay. But one of the reasons why surgeons like to hold back, if at all possible, is because it's often very difficult to determine the extent of the resection and how far to go. As well, the bowel wall is edematous, and getting closure may be a challenge, and often the abdominal wall is left open and the surgery treated more as a damage control, which is also necessary because a second look should be done within 48 hours in order to look for additional areas of necrosis that need to be resected. One other option to consider in specialized centers is the use of directed thrombolysis, similar to the endovascular treatment options explored in the arterial occlusions. Venous cannulation and thrombolysis can be considered. However, the outcomes are not nearly as good, and there's a considerable difficulty in getting access, requiring an awful lot of requiring a specialized center to do this work. And as is with the arterial occlusions, these people have to have no evidence of active infarction and complications from the thrombus. And so far, the use of thrombolysis has been very limited outside of specialized centers and clinical trials. Now, I've been saving the best for last because ischemic colitis is the by far most common form of ischemic enteritis that you're going to encounter in a critical care environment. It can occur across a variety of different conditions and is a challenging diagnosis, as many of these patients are seriously ill on their own accord and then develop the ischemia as a complication, or they're also elderly and have a lot of other risk factors for developing other diseases, making the diagnosis harder to identify. The circulation to the colon is derived from multiple arteries, including the superior mesenteric artery, the inferior mesenteric artery, and also the internal iliac arteries all supply portions of the colon. Unlike the small bowel, the large bowel has a significant amount of collateral circulation, which generally protects it against ischemia from a loss of perfusion. But there are several areas of watershed that are particularly at risk, including the splenic flexure and the rectal sigmoid junction. Ischemic colitis is different from the other two ischemic enteritises that we've talked about, because in this particular case we don't actually have a blood clot in a vascular system that is responsible for the ischemia. The vast majority of the ischemia occurs from a sudden loss of blood flow to the areas of the colon that are particularly hardest hit, or the watershed areas of the splenic flexure and the rectosigmoid junction. The colon itself is particularly vulnerable to ischemia, which you may think is a little unusual considering I've just talked about its extensive collateral network, but yet at the same time I've also said that it's the most common form of ischemic enteritis that you're going to encounter. Well, the reason for that is that the colon itself actually receives a relatively smaller amount of the total blood supply than the rest of the rest of the bowels. As well, the microvascular plexus is much less developed in the colon, and the colon wall is thicker than the small bowel, making small vessel occlusion much more likely. This means that infarction in the large bowel can occur relatively quickly within 8 to 16 hours of onset of ischemia. There are three major mechanisms for the development of ischemic colitis. Number one is the non-occlusive form, which occurs in 95% of the cases. This, again, as I've said, particularly affects the watershed areas. There's also a small proportion of people who will get a rare embolic or thrombotic arterial occlusion. And a lot of the reasons behind the risks for developing emboli are, again, the same as have been mentioned previously for the mesenteric superior mesenteric artery. But in addition, the colon is also at risk from any intra-arterial manipulations, or sorry, intra-aortic manipulations, including intravascular procedures, intra-aortic balloon pumps, and also from ligation of the inferior mesenteric artery that occurs during aortic repairs. Mesenteric vein thrombosis is a very rare cause for ischemic colitis, and we're not going to really explore that in any detail in this talk. The risk factors for developing ischemic colitis are very well defined and usually are fairly obvious and should be kept in mind when patients have had these procedures or have these risk factors to be watchful for the development of ischemia. Number one risk is any instrumentation involving the aorta or the iliac vessels, particularly repair of the aortic aneurysms. They will often involve ligation of the inferior mesenteric artery as part of the repair. These patients are particularly at risk for developing ischemic colitis. The left colon is particularly at risk because of this ligation. And so a lot of your investigations and index of suspicion should be high for ischemia of the left colon after this type of an operation. Other manipulations in the aorta also place the patient at higher risk for developing ischemic colitis. And this includes any intravascular procedures and interventions such as intra-aortic balloon pumps. The second important risk to recognize as a cause of ischemic colitis is cardiopulmonary bypass. Now, regardless of the intra-arterial procedures that are occurring during bypass, there is also specific risks of colonic ischemia that occur both intraoperatively and postoperatively. Bypass usually involves a relatively low flow state, and so placing the colon at risk in the presence of having low flow having a lower blood volume being delivered on a regular day, having bypass with a continued low flow state places the colon at much higher risk. As well, the blood is typically activated as it's been passing through artificial membranes, which activates the coagulation and the complement pathways, which leads to hypercoagulability and also microemboli, which then can then get into the systemic circulation and embolize into the large colon. Patients who have also had prolonged bypass are at particular risk, not only because of the bypass itself, but also because these are patients who are typically much sicker, have usually had some form of an intra-aortic intervention or device like a balloon pump, and are also exposed to higher doses of vasopressors, which causes more direct ischemia by vascular vasospasm, which all increase the severity and the likelihood of ischemic colitis. So the patients who come out of the OR after having been on bypass are at particular risk, and then subsequently, if they remain quite sick, may continue to have significant risk factors for developing ischemic colitis through the use of the vasopressors, as well as volume depletion that usually occurs as they're trying to keep the preload down as much as possible and trying to offload the lungs as well as the heart. Thus, it is therefore not entirely unlikely or impossible that a patient will present several days after bypass surgery with ischemic colitis, and this is unfortunately a well-recognized problem in the cardiovascular ICUs. There are a number of other risk factors associated with developing ischemic colitis, and this include myocardial infarctions and hemodialysis, which are also more related to the low flow states that are generally produced in those conditions. Patients who have inherited or acquired thrombophilias are also at particular risk, as well as any individual taking a variety of different medications, including diuretics, stimulants like cocaine, estrogens, other steroids which also induce a hypercoagulable state, antipsychotics, as well as HMG-CoAs reductase inhibitors. Finally, people who engage in extreme exercise are also at risk for developing ischemic colitis by virtue of the volume depletion and hemoconcentration, as well as the low flow state that occurs as blood is being shunted away from the splanchnic circuit, further complicated by hyperthermia and electrolyte disturbances. So it is not impossible, it wouldn't be unlikely to see somebody who's been running extreme marathons or triathlons presenting with colonic ischemia. Ischemic colitis presents with a usually rapid onset of mild cramping abdominal pain, with tenderness particularly affecting the left side of the abdomen if the left colon is involved. Usually some form of bleeding is present either occultly or obviously within 24 hours of the onset of the abdominal pain. But it is also possible to develop bleeding without any obvious abdominal pain. The pain quality is usually also not as severe. It's also a bit more cramping in nature, and as opposed to the small bowel ischemias, the location is more lateral as opposed to periumbilical. The ischemia, the clinical stages progress through 3 levels. First is the hyperacute phase, which occurs soon after the hypoperfusion or occlusion event, which is initiated with severe pain and then the freak passage of bloody stools. This is then followed by the paralytic phase, where the pain diminishes in quality, but it usually becomes more continuous and diffuse. The abdomen itself is much more tender and distended, and there's a loss of the bowel sounds. And then finally the shock phase, which heralds the onset of gangrene, where there's all of the systemic responses to the ischemia and the development of shock and metabolic acidosis that usually occur at the end of the spectrum of this presentation. Peritoneal signs are unusual and usually occur less than 10% of the time in patients who present with colonic ischemia. So don't rely on presence or absence of peritonitis in this case. Laboratory investigations are also nonspecific. As is the case with all the other ones, there's no specific marker for ischemia, but an increase in lactate is usually a cause for concern. The flat plate of the abdomen is again also very nonspecific. You may see evidence of distension, or if the condition is progressed, you may start to see evidence of pneumatosis. In this case, the CT scan is the test of choice for helping the diagnosis, and it is also usually the first test done in order to investigate for possible ischemic colitis. CT scans initially may be nonspecific and can usually be used primarily to exclude other causes for the abdominal pain, such as obstruction, volvulus. But the typical finding is that of segmental thickening of the bowel wall, which, while commonly found in ischemia, is also seen in other conditions such as infectious colitises. As the ischemia progresses to infarction, you will then start to see pneumatosis. Gas in the mesenteric and venous system is particularly ominous, as well as free air in the abdomen, which indicates that there's perforation. The presence of portal venous is rare, but it's obvious in that case the source of the problem is ischemia. The need for an operation is now completely necessary. There's obviously going to be extended bowel necrosis, and unfortunately, usually the outcomes are pretty poor. Making the diagnosis of ischemic colitis, while is a challenge, the suspicion should be raised for anybody who's at increased risk factor, who has evidence of any of the risk factors which I've described, who presents with lower abdominal pain and bloody diarrhea. When the CT scan is done and is usually found to have non-specific findings, in that case the next step is to usually move on to some form of lower scope in order to look at the bowel mucosa itself, which again also helps identify whether or not any clinical findings are related to any other causes, such as infectious colitis, and also help to identify the extent of the disease. On endoscopy, you will typically find, at least in the early phases, pale mucosa, and then this can then develop into hemorrhagic nodules. As the ischemia advances, you then start to see cyanotic mucosa, and then ulceration that may or may not be hemorrhagic. Occasionally you will also see evidence of pseudomembranes, and it's not unusual to confuse the pseudomembranes for an infectious colitis as opposed to an ischemic colitis. The advantage of doing an endoscopy sooner rather than later in this condition is that the biopsies will often help you make the diagnosis if it doesn't become obvious as the disease is progressing. The differential diagnosis for this condition includes both infectious colitis, inflammatory bowel diseases, radiation-induced enteritis, diverticulitis. Rarely we'll see rectal ulcers and colon cancers also presenting in this manner. Fortunately, the vast majority of people will resolve spontaneously over a few days with just conservative therapy only. Obviously, try to remove any ischemic insults that you can find, making sure that the patient's well is volume repleted, stopping any vasopressors if at all possible, and then doing frequent clinical examinations to look for evidence of necrosis, infarction, and peritonitis. For those who do progress on to irreversible ischemia, the only option is for surgical intervention. In the case of the development of shock or instability, again, the surgeon should be involved and should have already been involved in the patient's care to arrange for a more urgent surgical operation. For those who do recover, you will usually see evidence of improvement within a couple of days, and then the radiographic and clinical resolution will take another couple of weeks, but it usually will completely resolve. While there is no clear evidence for the role of antibiotics, most societies would recommend starting empiric antibiotics in these patients because of the risk of bowel translocation, especially in severe cases. Unlike arterial or venous occlusions in the small bowel, there is no role for anticoagulation in this condition, because this is not generally a embolic or thrombotic condition, but a low flow state, and so anticoagulation has no role in this. Overall, the risk of progressing on to surgery is about 20%, and is generally indicated for any evidence of hemodynamic instability, evidence of full thickness necrosis or perforation, and failure of symptom resolution over a few days with supportive therapy. Again, it's important that you have your surgical colleagues involved and following to facilitate surgical intervention if it becomes necessary. Well, that's all I have to say about this. Again, as is always the case, if you have any questions, please feel free to email me or just flag me down if you see me in the hallway, or if you're watching this on YouTube and you'd like, please feel free to leave comments in the comments section below, and I'll try to respond to you as quickly as I can. Thank you very much for listening again, and we'll talk to you later.